Hi everybody, welcome to the Becky and Boca Show. I am here at 3T Radiology and Research. I am with Dr. Daryl Eber, MD. I came here to get a full body MRI scan.
So yes, you came here and you had a whole body MRI, and then we sat down and we went through the full exam. And it's actually an exam that's different from the traditional MRI. This basically gives you more information, which, as we spoke about at the time, you're very interested in seeing what's going on. You're also very interested in preventative health.
Right.
You wanted to make sure, and wellness, right? You want to make sure that you potentially don't have an early cancer that can be detected early. Now again, this test isn't 100%. You know, it's not going to detect every single thing, but at least it gives you information that you wouldn't otherwise have.
We're able to look inside the body and see what's going on.
That's correct. But one thing I just want to add is that the technology has improved, so we're not just going to go and look for, get a bunch of findings that we're going to have to chase down. With our scanner here, we have a 3T MRI with advanced protocols, so we're able to really get a more accurate exam.
And I think that's important because these MRI scanners have been around for quite a while, but the technology has improved greatly in recent years.
Yes, again, it's not 100%, but the technology has improved greatly, and also, we modify it, some of the protocols, to make sure that we try and get as much information as possible so that we can get an accurate diagnosis.
Okay, doctor, can we go take a look at the scanner?
Absolutely.
And then we're going to sit down at the computer and look at my results.
Sure.
Okay.
This is the 3T MRI. We have to be careful because it has a magnetic field, so obviously we keep the door shut. This is powerful enough to lift up 2 cars. That's how strong the magnet is, yeah. So we get a lot of good signal from your body. And the other thing too is that since it is a high field magnet, it's what we call a high field magnet that has a 3T MRI, and there's different strengths. This is the highest strength right now that's in an outpatient center. They do have higher ones in the academic centers, but it also gets a signal faster. So it gets more signal and signal faster. So that means a shorter exam.
Okay, and about how long is a typical exam?
So the whole body exam, since we're doing multiple areas of the body, it's longer than like if you were just to get an MRI of the knee. But generally speaking, depending on the patient, 45 minutes to an hour and 15 minutes.
There's the scanner. You have a tech that sits right here. When the patient goes into the scanner, she's watching them, communicating, correct?
Yes.
Okay.
Technologist is trained to make sure that you're safe to go into the MRI. They put you in very comfortably on the table, and we control everything. The other thing is that you have complete control when you're in there. So you're in communication with her. Also, we're in communication.
I remember being able to talk to her.
Exactly.
And if somebody is very, very anxious, you could prescribe a medication?
Yeah, exactly. So what we'll do is, and again, I have to consult with the patient, but we can give Valium.
You have a consult before.
Exactly, and then make sure that it doesn't, interact with any of the other medications you have, and it's safe to give you. Then yes, you can have something like Valium, which does help. If you get claustrophobic, I mean, again, this magnet hopefully will mitigate that because we have a larger hole.
Didn't they used to say that the tighter the better on MRI scanners? Has that changed?
Yeah, no.
That was old school.
Actually, it's interesting. There's some advanced physics, which I don't want to bore anybody, but but really, what the coils, the things that we place on top of you, or like that cage sometimes that you have over your head, that gets as close as it can to the body, and that's what
that's
it is.
for.
Yes.
Okay.
So it's not necessarily
doesn't have to be that.
Really, what the MRI does, the magnet itself, that kind of changes the magnetic field, the electromagnetic field, stuff like that. So that's what that's there for. And the other thing about this magnet, which is nice for patients' comfort, is that it's a little bit smaller. So you have a larger hole and it's a shorter magnet. So you're not in a long tube.
Yeah, I see what you're saying.
So that way you don't feel as claustrophobic.
Right, you don't feel like you're stuck in there.
Yes. And I can say that I've personally been scanned there, so and it's comfortable. And I do not like MRIs. So.
Right. You don't like MRIs.
Right.
It's okay. I think that's what a lot of people are worried about. When I did it, I anticipated being nervous or being a little claustrophobic, but I was not.
You'll be comfortable, you'll be listening to music, and you can be in touch, and you have a button to press if for whatever reason you need help or you want to come out.
It's a big open tube, and
correct.
You can get out.
Yeah.
Okay.
And we can help you. So
okay.
It'll come out a lot faster if we help you. But yes, you can crawl out.
If you had to.
Right.
So our technologist is getting the table ready and getting the MRI ready to have a patient come in. We make sure that everything is very clean for every patient, it's very individualized for each patient, make sure that you're very comfortable. The table that you see there, that comes down, so it's very easy to sit on, it's very easy to get off of. We also have other pads that can make it very comfortable for you when you're lying down on the table, especially if you have a bad back or anything like that. Like, we try and help you so that you're as comfortable as possible.
Okay, Dr. Eber, you have pulled up my scans on the screens here. You want to tell us what we're looking at?
Absolutely. There's a few things that are very important on the exam.
Okay.
The first thing is overall structure, the size, the character of the organs, right? So we have all the organs.
Okay.
You have your liver, your spleen, the gallbladder.
That's
the
what we were
kidneys.
looking at here.
Correct.
Okay.
On top of that, you also have lymph nodes. So, and we see lymph nodes very well, even without the contrast in many, it depends on the patient, but we can see there's a very typical pathway that a lot of the lymph nodes follow. And we're able to see, like, for instance, in the back here by the aorta, you tend to have a lot of lymph nodes lie in this area. And this is a way that the metastasis kind of goes throughout your body. So
through the lymph nodes?
It goes up, many tumors go through lymph nodes. That's the way that they spread, like the metastatic deposits go through lymph nodes, the lymphatic system. Some go through the vascular system, but that's one thing that we can see pretty well with the MRI. It delineates it well. Contrast does help sometimes, especially if you're someone that's really thin without, here you can see good differentiation between the large bowel and the organs, and there's intra-abdominal fat. Some people just don't have that for whatever reason. They just don't have it. So everything's kind of on top of each other. In that case, sometimes the contrast is more helpful.
Okay. So what is the difference between doing this MRI scan without contrast, which is the way I did it, or with contrast?
The contrast kind of helps us look for certain things that the without contrast can't see.
Okay. Now by contrast, that means you inject something
Correct.
into the person prior to the exam.
As we're going through the exam, we give contrast. So we'll take the pictures without the contrast, and we'll give you the contrast. It's done through the IV.
Okay.
And then we also make sure beforehand that you're not allergic to it, that you're okay to have this. It's not going to cause any detrimental health. And also you have your overall functioning is good. Your kidney function is good, because that's one way that you clear out this contrast. So
okay.
And again, it's an option, but it does increase the time of the scan. I just want to, because we're taking extra pictures both with and without contrast. Here I have your brain pulled up. A few things we're looking at: the overall brain volume. We're looking for abnormal signal, abnormal structure, things like that. We really get a good picture of the brain. We get a picture of the spine. That includes the cervical spine, the thoracic spine, the lumbar spine. And again, this is a screening exam. So if we do see a few things, we may want to go back and take a more detailed look and look at it and that would be the full diagnostic, like lumbar spine, especially if you're having back pain and things like that.
Okay.
But we get a really good idea of what's going on, including looking at the spinal cord itself. And I'll just show you really quick. If you look here, so we can see the whole cervical spinal cord, and we can look and see if there's any mass or if there's any abnormal signal. The other thing is that structurally we can look at the intervertebral discs, and here you can see that this is kind of bowing out, like and so there's obviously some pathology there, likely remote, chronic, but that could explain some neck pain that you're having, and you may need to get that looked at.
Okay.
But overall, the overall structure of the spine looks good. The brain, the overall structure looks good. We can even look and see if you have pretty bad paranasal sinus disease.
Oh.
We can look into the orbits, look behind the eye.
Wow.
I mean, again, it's not 100%, but at least it gives us an idea of kind of what's going on. And again, information is the key.
Right.
Here you can see this is one of the major arteries at the base of the brain. This is the basilar artery. And kind of towards the tip here, as it go and it branches out, sometimes because of the turbulent flow, you can see like a basilar artery aneurysm.
Okay.
And so that we can kind of, it might hint at that. There's things that give us kind of secondary like clues that you may have something going on. We do have a dedicated sequence for that, so some people are just genetically predisposed to developing that, and we can certainly add that on after the consultation.
Oh, that's interesting.
Yeah.
Okay.
So this isn't just one size fits all.
Right.
Like in general, it's a screening exam, but we can tailor it to what your specific needs are.
So certain people are coming in with certain concerns, and you could tailor the exam to their concerns.
As we age, a lot of times we get like almost a degenerative process, not something that's like the big neurodegenerative diseases that you hear about, like Alzheimer's disease, but little smaller ones that are because your vessel's a little bit more brittle as we age. So we can kind of look at that and we can kind of grade it, and we can give you just an idea and assessment on where you're standing when it comes to that kind of chronic degradation.
Okay.
And also we can see if you're having maybe, we call them, it's like atrophy of the brain, maybe a little bit more than you should be for your age, then you may want to go into your doctor and get checked. It doesn't necessarily correlate directly with Alzheimer's disease, but at least it's something that you might want to, bring up to your doctor and then have a full neurologic exam and a memory test and everything else.
Okay.
One thing that we do in conjunction with the MRI is the MRI doesn't look at the actual lung parenchyma itself, meaning like the lung tissue. It doesn't, because of the air, it just has to do with the physics. So we do a screening CT of the chest. And that will look for pulmonary nodules.
Okay, so you do that separately.
That's separately,
but
yes.
that's included in the.
Yes, and that's also a much faster exam. So that takes by the time you sit on the table and go through it, it's 5 minutes.
Okay, so you get the MRI and then a CT scan of the chest.
And also, if you're concerned about coronary artery disease, we do a CT screening calcium score. We can do that. We can add that to it. That's fairly simple. It's better to do CT. The MRI doesn't look at the lung parenchyma itself. Big masses it can pick up, but again, that's the early detection of the smaller nodules, especially if you're at risk.
Okay, so we did this on me, right?
This is your exam here.
And we're looking at the lungs?
Yes. So we can see your thyroid glands. We can see if it's large, if there's any nodule. We also look at that on the MRI as well, but here we get a good picture of that. We look at the aorta, the thoracic aorta. We look at the heart. So we see the size of the heart. We make sure you don't have a pericardial effusion. We make sure that you don't have extensive coronary artery disease. And then when we can also get a picture of the breast. Again, this is not a screening exam for the breast at all, but at the same time, sometimes we pick certain things up, or we can pick up axillary lymphadenopathy. In the lungs itself, so CT does a very good job of looking at the lungs, and we can pick up, the lungs are full of air, all the small airways and the larger airways. And that just isn't imaged well with MRI, but on CT we see it very well. So we actually can look and we get high resolution images. We do all kinds of fancy things to get a better picture to make sure that we don't miss any of the pulmonary nodules or any mass. Also, this can show us if you have any kind of chronic disease. You may have unfortunately, a lot of patients that have breast cancer, they go through radiation, they get radiation-induced pneumonitis, which is a little bit, they can get some scarring, they can get, just chronic changes in their lungs. Overall, it's really mild, a lot of times doesn't affect the way that they breathe, but it may be helpful because if you know that your lung capacity might go down, you might want to go, especially if you're going to travel to the mountains or things like that. Again, this is where the knowledge and information is powerful to you. And also we can look at the coronary arteries for the calcium. This is different than when they do what they call a coronary CTA, which is CT angiography. That's where they give you contrast, and they really get a good picture of both the calcified and non-calcified plaques. What they developed is a quicker screening method just for looking at the calcium burden of your coronary arteries. And
so we're trying to see how we're doing as far as health of the heart?
Yeah, and then your, what your heart status is. In other words, this is
your likelihood of having
a
cardiac
disease.
problems.
Yeah,
okay.
Like if you're having existing heart disease and if you're at risk for developing a myocardial infarction, like a heart attack.
Right.
This is something that the cardiologists use to stratify patients to see if they need to do further workup. So,
okay. All right.
And then basically just to show you, so we get a very good idea of the structure of the heart. These are the great vessels, including the pulmonary arteries, the aorta. But then when you look at the individual coronary arteries, we get a good picture of the LAD, the left circumflex, the obtuse marginal, the right coronary artery. And what we're looking for is there any calcification that we can measure? And then what we do is we can give you a score. Once we give you a score, then that stratifies your risk. In this case, you have a very good heart and coronary arteries.
Yay.
So your score was 0.
0, okay.
And how? So just so you know,
it doesn't mean I'm
right. Doesn't mean you're completely out of the
right.
clear. You still need to be healthy and and follow your doctor. And if you do have chest pain, you need to see your cardiologist. You may need a stress test because there are some lesions in the coronary arteries that are not calcified.
Oh, okay.
And those actually are the ones that can be more deadly because those are more acute injury to the wall. They can cause the thrombosis, which then goes downstream and causes the heart attack. But at least you know, at least we can say that, you know, you haven't had a lot of damage to the coronary arteries.
You don't have the buildup. That's what you're
exactly.
looking for. Okay.
Right. After we get that information from the chest, and then and the MRI is great at looking at inside the abdomen and the pelvis. You can see we have a really good idea of the liver. We can even see what's going on inside the liver. We can look for masses. We can see the ducts, which go down to the gallbladder, even the common bile duct, which goes from the gallbladder all the way down through your pancreas into the GI system. We can look at the pancreas. We get a good picture of the pancreas. And even here you can see the pancreatic duct. We can look and see if there's any surrounding inflammation. It's amazing. The detail is pretty amazing on this. That we can see a pancreatic duct all the way to the pancreatic tail. We can see here's your stomach here, so we get a good idea of what's going on in your stomach. You can see the large and small bowel. We have the spleen. The spleen's over here. We have the kidneys.
This is fascinating.
Yeah, we can look at the kidneys. So we can look structurally at the kidneys, meaning that, you know, what's going on in the actual renal cortices, but then also if you have any hydronephrosis, meaning there's some obstruction. One thing, there's a limitation when it comes to calcification in the kidneys. So if you do have a history of like kidney stones, things like that, MRI is not the best choice, but at least structurally it's really good at looking at kidneys. Also, if a lot of times you may have been told you have a kidney cyst, we see that very well on MRI. We even see the adrenal glands. So the adrenal glands kind of sit on top. Here's the adrenal glands. It's another organ we can see well. And the other thing that's great about the MRI is that, you know, with certain techniques, we can just say, okay, this is a benign adrenal lesion, so you don't need any more follow-up. That was always one big thing, like almost a red herring that a lot of the doctors would talk about, like, well, we don't want to scan your whole body because then we're going to find this stuff and we don't know what to do about it. But the technology is so good now with MRI that we can actually give you a definitive diagnosis. There might be some things we need to follow, which would be normal, but again, it's better having the information than not having it.
Right.
These are just benign cysts, very common. They tend to be in the sacrum. They really don't cause any symptoms. They're very pliable, so, you know, but occasionally they can get very, very large and they need to be dealt with, but that's something that the MRI does a great job with. We can look for rectal prolapse, we can look for vaginal prolapse, there's a lot of different structural things in the pelvis that we can look at. And that sometimes helps because depending on the positioning, that could cause symptoms, right? So it's not just that we're looking for cancer or
I think that's everybody's
disease.
main concern is that they're looking for cancer, but there's other things that you can pick up.
There's some other structural things, like, you know, I've talked with patients and they're just like, you know, I've had this my whole life and I just don't know what's going on, and it's, you know, I don't know what this, you know, why am I having this, or why do I get constipated with this, or, you know, it's not that we're going to give them any definitive answers, but sometimes structurally they're different. They may have a deeper pelvis, they may have redundant loops of bowel, you know, and these things are always good to know. And they may have implications later on in life. And again, when we do the MRI of the pelvis, it differs between the men and the women. In your case, we want to make sure we take a look at the uterus. That includes the endometrium, which we can measure the thickness of the endometrium, which is really important.
And you're looking for what kind of cancer?
Endometrial cancer, that's a big thing. And that, you know, if it's, depending on if you're a postmenopausal woman, your endometrium shouldn't be thickened because, you know, as you go through.
Okay, does this look for cervical cancer too?
Yeah, so that's the other thing too. We look at the cervix and we look at the just make sure there's no masses, and also look at the cervical canal. We make sure there's no fluid there. Also, there's some benign masses, believe it or not, of the cervix, and we can see those very well here because they tend to be more cystic.
Okay.
But again, this doesn't supplant the normal, you know, screening exams you have to do with your OB/GYN.
Absolutely.
And, you know, even the pelvic ultrasound, because those are very good at what they do. And one thing I want to mention is that the pelvic MRI for the men is different because we have to look at the prostate gland. The difference between men and women, you know, we do a little bit higher resolution and a few other sequences for men to look at the prostate. A couple things when it comes to the prostate gland. Number one is we can look at the overall size. So that's important, not just for prostate malignancy, but also for benign prostatic hypertrophy, which causes symptoms. You know, you can have frequency.
And this is a concern for most men as they age.
Yeah, unfortunately, that's something that we all have to deal with. Our prostate's just an issue. You know, if we could live to 150 years old, then we probably would all develop a very bad prostate abnormality.
Okay.
But yeah, so what we do is, and again, this is in conjunction with what your normal test would be. So they look at your PSA values, And so, you know, that's something that's being screened. Sometimes you might go for just a regular screening exam with your doctor for the prostate. This is in conjunction with that.
Okay.
And then if we happen to see something that shows us something that looks suspicious, like the abnormal signal, then you do a full prostate MRI. And that's with and without contrast.
Okay.
So we really get a good look at the prostate gland, the seminal vesicles. We get a good look at the bladder. We even get a look at the scrotum, so we can look at the testicles, because sometimes later in life, most times we think about testicular cancer being somebody that's young, they can get testicular cancer, but you can also, there's another high incidence when you age, when you get older.
Oh, okay.
So we can take a look at that as well. That's within the field of view. And then, the other thing that's important in the pelvis is looking at the other structures that are there. So it's, the distal colon is there, the rectum is there. We get a good look at the rectum. These are all
And what are you looking for there?
Wall thickening, looking for abnormal stranding. Just the other day there was a case that I had, a patient was having kind of mid-abdominal pain, and it ended up being that they had primary rectal cancer, which we could see on the exam.
You can see that on the exam.
Yeah. And then, and it depends on the stage. If it's very, very early on, again, this is not 100%.
Right.
So, and the other thing is that on this kind of MRI, it just depends, because the large bowel and small bowel, they're kind of dynamic. So they're moving, they're peristalting and things like that. So this isn't the best test. This doesn't supplant like a screening colonoscopy, but if there are abnormalities that are there that, that maybe you have some symptoms or maybe you don't have any symptoms, it's at least something that says, hey, look, we need to take a look at
that.
The third thing that's very important is the vascular system. So we can pick up like an abdominal aortic aneurysm that you may not have known that you have.
Oh.
So we can see if the actual abdominal aorta is dilated, or if some of the branch arteries are dilated. Sometimes we can pick up some abnormal signal, which could say you have other vascular things that need to be taken care of. We can look structurally at the bones in the ribs.
Oh, wow.
So we can really take a look at what's going on. We can see the sternum really well here. A lot of different diseases, including metastasis, tend to hide out in the sternum and aren't picked up well, but we get a good picture of that. And we can see the ribs really well. And again, we get this on multiple views, so we can take a look. We look at the scapula, we look at the clavicles, we get a good picture of what's going on. And again, there's some overlap in some of the upper abdominal structures with the MRI, but for the most part, this gives us a good picture. So then we're looking at, we looked at the head, the brain, we're looking at the spine, we're looking at the chest, we're looking at the abdomen, we're looking at the pelvis, really get a good understanding of what's going on.
Of what's going on in your body.
After speaking with you, you were concerned about your carotid arteries. So we tailored the exam for you. And we added on a carotid ultrasound, which gives us a good idea of, when we're looking at the carotid arteries, we can actually look at the velocity of the arteries, we can look at the structure of the carotid arteries, and we can see if you have any
And this
stenosis.
is important because that's blood flow to the brain?
Correct.
Is that right? Okay.
So if you have high-grade stenosis, then you're not perfusing your brain enough, you're at significant risk of developing a stroke.
Ah.
You're at low risk anyways because you didn't have a lot of vascular calcification, but you were concerned about that. This can pick up certain aneurysms, but we do another series on MRI, which is an MRA neck, which basically that's MR angiography, and that doesn't use any contrast. We can do it without contrast, but that can look at the structure of the vessels and then see if you have any aneurysms. Typically, the aneurysms are pretty rare. It's not something that we need to screen for. Here we were able to get very nice images, and there's color on these, so we look at there's normal flow. So, every time that I read these things, they remind me of, when the cops kind of try and get your velocity when you're speeding with the speed guns. It works off the same technology, very similar technology. So in your case, we really got a good idea of what's going on in your body. There were some recommendations that we went through, which you need to follow up with. And then, again, if you have a past medical history of cancer or things like that, there's certain other things that, we can discuss that may be a little bit more.
I would imagine a certain amount of your patients are here because they have had cancer in the past and they want to screen to make sure there's not a metastasis. Is that right?
Yeah, it's a little bit different. Like, in other words, if we're just, you've been an otherwise healthy person and we just want to see what's going on in your body, we want to take a look at the organs, we want to see structurally, physiologically, like see kind of what's going on. That's a little different than somebody that's had cancer. So that's part of the consultation. Because
Right.
in that particular case, we might want to add contrast. There's some other things that we may want to do, depending on how far out you are or what's going on with your current care. And sometimes it just may not be the right exam for you. You may want to just follow with your doctor and make sure you're going through the normal steps, because
Right.
you know, they may have you doing PET CT scans, they may having you do, you know, other things that are a little bit more involved. So there's certain screening exams which are very good. You know, pap smear and you know, get your clinical cervical exam, those things you want to continue to do. When it comes to colonoscopy, once you meet a certain age, you still want to be doing that. This doesn't replace mammography, you know, things like that. This is just something that's complementary
Right.
to all those things.
In addition to.
Yeah.
Okay.
And again, I think the best thing to do is, you know, be in consultation with your doctor who's taking care of you, and then, you know, do this in conjunction with other laboratory tests they might do, like tumor markers, things like that.
Okay.
But you know, I'm happy to help you out in any way.
Okay, and for the average person that's getting this done, how often do you recommend doing the full body MRI?
That's a great question. There's not a lot of data on how often someone should come. If you want to say, look, I want to make sure I have no disease whatsoever, you know, we could scan you every single year, and then in year 3 or year 4 or year 5 in one day, you can develop disease that day, right? But I think that, you know, the way that I look at this is it's kind of when you look at people that have remission of cancer and things like that. So they go over a certain period of time. If it's not coming back, then they essentially say that you're clear. So that's the way that I look at that. But again, there's really no good evidence-based medicine studies looking at that. So, and I right now I'm not recommending that for like myself or my family just to go and do a yearly one. You know, like again, if it's something that you want and you're concerned about that, then okay, you know, getting a good picture of what's going on, and that's relatively clear, then continue to follow with your doctor. If you're symptomatic, you go see them, and then if you have the regular screening stuff, then that might be good. Maybe this is something that you want to do once every other year, once every 3 years, once every 5 years.
As an adjunct to your normal care.
And the other thing is that I think that this pairs nicely with some of the other things that are coming out now. There's newer technologies for longevity, anti-aging, things like that. So, you know, we're learning more and more about that, and some of the sequences I'm working with in research. I'm doing some advanced liver scanning where we're quantifying the amount of fibrosis, quantifying the amount of fat in the liver, how much iron is in the liver. And the other thing is that we're also looking at, we're using MRI to actually do what we call a virtual biopsy. So we're able to, without sticking a needle, we're able to see how much iron you have in your liver, how much iron do you have in your brain. There's studies that have come out which show that, you know, patients with Alzheimer's disease that have high iron content actually do worse cognitively. So this is advancing very fast. Matter of fact, it's advancing beyond what our even knowledge is, right? And so that's why I think in medicine it's very important that you go and speak with a specialist. This is all that I do. You know, this is what my specialty in medicine is. The actual study itself is sent to, we have doctors, myself included, but we have a group of doctors that are all board certified, fellowship trained radiologists. That's very important. So when you have a fellowship trained radiologist, that means that they did the full diagnostic radiology, but then also they went to additional specialty training. Kind of like you have an orthopedic surgeon, you have a general surgeon. Just everyone's there, we work as a team.
Okay, and then you generate a report, which you give back to the patient, and the patient can keep that and share it with their doctor if they want to. Okay.
And also they get a copy of all the images. That's all your data. You get it burned on a CD, so you can take that. So you have access to that at any time.
Okay, everybody, thanks for joining me in this episode of the Becky Imboka Show as I brought you the 3T Radiology and Research. We met with Dr. Darrell Eber. We talked about the MRI scans and all this interesting technology. I was fascinated. I think it's great. I think all you people are going to be very interested too.
Thank you. Yeah, it was my pleasure.
Thank you, Dr. Eber. All right. Bye-bye. See you next week.
Bye-bye.